This is an overview of an article entitled Effects of Delivering SLCO1B1 Pharmacogenetic Information in Randomized Trial and Observational Settings, published in the September 2018 issue of Circulation, Genomic and Precision Medicine. Pharmacogenetic testing for drug-gene pairs represents a potentially important avenue by which genetic testing might improve drug safety. Statins are widely prescribed to lower low-density lipoprotein cholesterol, or LDL-C, and to prevent cardiovascular events. However, statin-associated muscular symptoms, or SAMs, can develop as a side effect affecting 5% to 15% of patients. SAMs is frequently cited by patients as a primary reason for statin discontinuation and is associated with higher cardiovascular morbidity. Therefore, from the patient and provider perspectives, SAMs represents a significant barrier to reducing cardiovascular risk. Genetic contributions to SAMs have been identified. A previous genome-wide association study of severe but rare simvastatin-associated myopathy identified a common reduced function variant, the STAR5 allele of the solute carrier organic ion transporter family member 1B1, or SLCO1B1 gene. This association has been extended to statin myalgia and premature statin discontinuation. Based on these and other findings, professional groups and society guidelines have recommended either genetic testing prior to using high-dose simvastatin or simply avoiding it altogether. However, the efficacy of this genetic testing remains unknown. In the study in the paper under discussion, the authors investigated the hypothesis that compared to a strategy that does not incorporate genetic testing, delivery of SLCO1B1 STAR5 pharmacogenetic information to patients would improve statin adherence and statin prescribing and lower LDL-C levels. To test this hypothesis, they utilized multiple complementary approaches, including a randomized clinical trial. The authors used two study designs to test this hypothesis. First, they performed a randomized controlled trial with 159 patients who were not currently taking statins due to prior SAMs. They randomized these patients in a one-to-one manner to receiving SLCO1B1 genotype-informed statin therapy, or GIST, versus usual care, or UC. They followed patients for up to 8 months. The primary outcome was statin adherence, as assessed by the Mirsky Medication Adherence Scale, or MMAS. This was only assessed among those who reinitiated statins. Secondary outcomes, which were assessed among all patients, included statin reinitiation and LDL-C levels over time. Second, the authors performed an observational study using commercial laboratory data, monitoring serial LDL-C in 1,907 patients who had received SLCO1B1 testing. They then performed propensity matching with untested control individuals, and they compared the LDL-C levels between these groups over time. The flow of patients through the randomized trial is shown on the left. Further details are available in the online version of the paper. In terms of the primary endpoint, at the 3-month follow-up time point, 62 of 159, or 39%, of the patients reported statin utilization and completed the MMAS. There was no difference in patient-reported adherence to statin therapy between the GIST and UC groups. Similarly, at 8 months, 50 of 159, or 31%, of the patients reported utilizing statins and completed the MMAS. And again, there was no difference between arms. The proportion of patients who self-reported receiving a statin prescription between randomization and 3 months was higher in patients allocated to GIST versus UC, as shown in the bar graph on the right-hand side of the slide. However, there was no difference in statin reinitiation between 4 and 8 months after randomization, with overall rates much lower. As shown in the line graph, LDL-C was significantly lower in the GIST group compared to the UC group at 3 months with a similar but non-significant direction at 8 months. In an analysis of LDL-C over time using a mixed effects model, however, the effect of GIST on LDL-C was not significant, with a p-value of 0.22. In the observational cohort, among 143,757 patients meeting inclusion criteria, 92,271 had received SLCO1b1 genetic testing as part of their initial testing and had genotype-informed statin therapy recommendations returned to their providers. Upon one-to-one propensity matching, 1,907 patients who received SLCO1b1 testing were well matched to those who were non-tested, with the exception of female sex. Over time, patients who received SLCO1b1 testing had a larger drop in LDL-C levels, as shown here, although the absolute magnitude of reduction was less than 2 mg per deciliter per year, compared to propensity-matched, non-tested individuals. In conclusion, the investigators observed through a combination of trial and observational methods that SLCO1b1 genotype-informed statin therapy did not affect self-reported statin adherence, although it did double the number of new statin prescriptions initially, with the uptake diminished in longer follow-up. Lower LDL-C levels were observed in the tested group. The trial findings of the impact of genetic testing on LDL-C lowering were supported by observational data. These findings suggest that the pragmatic delivery of SLCO1b1 genotype-informed statin therapy might lower LDL-C levels without improving statin adherence.